Hello guys and welcome to another episode of the Protrusive Dental Podcast. Today I've got Endo Queen, Kreena Patel on the show today, and we're talking all about cracked teeth, something, as you'll hear, I absolutely despise in general practice. I think it's the bane of my existence. It's one of the most difficult things to sort of diagnose sometimes, and the amount of conversation that's involved with the patient, the amount of sort of discussion and complexities and nuances and possibilities. Your tooth might not even be able to save your tooth. We might have to put a crown on, but if then it fails, you might end up having to remove it. You may or may not be better off having an implant. The success isn't that good. I'm not even sure which tooth it is. These are sort of things that you sort of end up discussing when it comes to cracked teeth. So we're going to be discussing things like how far into a canal orifice does a crack need to extend before you look and say, you know what, this is unrestorable. And we're going to discuss about diagnosis of cracked tooth, which is one of the most challenging aspects of cracked teeth. And we'll also discuss about how Kreena suggests it's managed endodontically and also by us in terms of cuspal coverage. So I hope you enjoyed the episode. The episode, as well as everything from episode 20 onwards, is going to be eventually on dental tubules for enhanced CPD. So thank you dental tubules for quality assuring my CPD. So if you wanted to get your CPD hours in, then you can go to dental tubules, search Protrusive Dental Podcast, answer a few questions, acknowledge the aims and objectives, and there you are. You'll have CPD, enhanced CPD for this meeting. We know with all the outcomes written there, it's all well and proper. So the protrusive dental pearl I have for you is an endodontic one. And it's the one that actually Kreena gave me in the middle of the episode, actually. She told me when we're using a tooth slooth, which is one of those rigid plasticky thingies that you put on the teeth and you get the patient to bite together. And what it does, it flexes the tooth to then see if you are confirming the diagnosis of cracked tooth, basically. So that's essentially how you do it. And Kreena talks a little bit more about that. When you're using that, one thing that I don't do as much at the moment, I had done it on occasion, and I found, oh yes, this helps, but I never really made it protocol, was to actually, once you get the patient to bite down on the tooth slooth, you jiggle it a little bit, just jiggle it, because that sort of jiggling can then sometimes be the difference between being a negative result and a positive result, and that positive result is obviously important in your diagnosis. So the protrusive dental pearl donated by Kreena Patel is, when you're using a tooth slooth, make sure you jiggle it. So I hope you enjoy the episode. If you're listening to it, then awesome. If you're watching it on YouTube, then even better, because there's at one stage a photo of a cracked tooth that I show. So if you are listening, then reference back to the video version on YouTube and IGTV to look and assess that clinical photo of a crack that I will show. Because it's an interesting point that she raises about the width of the crack. So sometimes it's helpful to see the crack. So let's all learn from Kreena. Kreena Patel, welcome to the Protrusive Dental Podcast. It's great to finally have you on, and we're going to talk all things about cracks today. How are you?
Yeah, very good. Thank you so much for having me on.
No, it's really something that's been a long time coming, and to put some context into this right now, we're in the middle of a COVID-19 lockdown. So if you're listening in the year 2025, that's what's happening right now. And Kreena is going to be giving us some expert knowledge and advice about cracked teeth, because this is the time to sort of gain more knowledge and skills so that when we go back into work, we're fully charged and ready to go. So Kreena, for those very few people out there in the world of dentistry who don't know who you are, can you please tell them about who you are, what you do? But I'm going to give you a little introduction in the sense that you are one of the most proactive, most approachable, friendly and giving endodontists I've ever met. So now over to you.
Oh, that's lovely. Thank you, Jaz. Yes, I graduated from Manchester 2010, following a couple of years in general practice doing DF2. I then moved on and did my specialist training at King's College London, and I graduated from there in 2016. So since then I've been working mainly in specialist practice. So I work based over in Croydon and in Reading. And I also teach 1 day a week on the MClin Dent specialist programme for King's College London as well. So it's quite nice having a little bit of variation in my week, which is always nice. It's also quite nice giving something back. So being able to do a little bit of teaching, whether that's lecturing or working at King's, just keeps you nice and fresh and motivated.
I can see that you enjoy the education part of it from, based on what I see on your Instagram. And I think I can sense something you enjoy.
Oh, definitely. Yeah. I mean, I think when everyone starts, endo's never the thing that, people love. But with practice, I think endo can be really fulfilling. There's so many different aspects to it. I feel like every case I treat, I find something different, or I learn something different. And endo has, as well as being obviously quite a restorative specialty, there's quite a lot of surgery involved in it as well. So it's got quite a good variation. And the surgery is, fairly complex surgery. So I just think there's things in there that mean that you'll never get bored. So yeah,
two quick
speciality. Highly encourage people to think about it.
Brilliant. Well, the two things I want to ask you before we talk about the main theme of cracked teeth, and the two things is one, what percentage of your practice is surgery at the moment? And the second one is how big of an impact has CBCT made in the last 5 years in your daily practice?
So not a very large percentage is surgery, actually. I'd love to do more. It's just when you learn about doing endosurgery, you realise case selection is so important, and the majority of cases can be treated non-surgically. So as long as they're treated well, quite a significant portion heal with root canal treatment or root canal retreatment. So most of my week is doing that. I'd say about 5% is surgery. I do a little bit more at my teaching job where I supervise surgeries for the postgrads. So that keeps me quite involved in it. But yeah, I mean, I wish I would do more, but it's just that, most things heal without surgery, which is a good thing for the patient, I guess.
And then how about CBCT?
Yeah, I mean, CBCT's had a massive impact. It's almost like a whole lecture. There's so many applications to CBCT and endodontics, from, whether it's diagnosing periapical lesions, because quite often on radiographs, they're 2D x-rays. So, sometimes for patients with difficult, signs and symptoms, we can't really diagnose properly. A CBCT is game-changing because you suddenly see where the problem is, because we see significantly more periapical lesions on CBCT than periapical radiographs. Also things like resorption, so things like internal resorptions, external resorptions. It allows us to plan these cases without going in surgically or doing any invasive treatment. We can instantly see what we're looking at. So it's game-changing for that. Even things like endosurgery, it's fantastic. We can plan the treatment. We can see the proximity of lesions to the sinus, mental nerve, ID nerve. It allows us to do more complex treatment, surgeries on lower molars, which we probably, wouldn't have taken the risk to do before. Trauma, it's fantastic for trauma. So many applications for CBCT in endo. So we've actually just bought one for our Croydon practice. You have to be a little bit more careful when choosing cone beams for endodontics, because you need a much sharper image compared to for implant surgery, because we're looking at obviously tiny canals and you need to see that sort of detail. So it's a little bit more difficult to pick a scanner when it comes to endo.
We do have in the Richmond practice, there is a very good CBCT scanner with an endo mode, and I think that's what, it's just higher detail in that area for when you need it, so it is different. So on the topic, I mean, I've got a list of questions I want to ask you about cracked teeth, but now on the cuff of cracked teeth and CBCT, when you take a PA, and we all do this, we take a PA and we show the patient and we suspect cracked tooth, and the first thing we say to the patient is like, well, I need this x-ray, but I'm not expecting to see the crack on this x-ray, and we all say that. Where do you see cracks on CBCTs?
It depends on the size of the crack. So there's been quite a lot of research that came out on this, and the initial research said we can see cracks. But what they were doing with that research is they were making the cracks a little bit wider than what we would, something that we would see in the mouth, for example, that we wouldn't need a cone beam for. So initially, a lot of the studies said, cone beams very useful for diagnosing cracks. Then the later studies were making very hairline cracks in teeth and then looking at that. And what we found is actually on cone beam, we don't see cracks at all, very fine cracks, that is, on a cone beam. In fact, because cone beam has a smaller resolution than periapical radiographs, we're less likely to see it on a CBCT compared to a radiograph, for example.
Oh, right.
The thing that we do see, though, is we quite often see the bone loss associated with a crack. So if we have a vertical root fracture, quite often clinically we get a localized deep pocket associated with that. And that would be, there'd be bone loss associated with that. And those fine details we see a lot better on a cone beam. So the associated signs are there, but not the crack.
Well, I think it's fair to say that if you can see a crack on the CBCT, that tooth is probably for the bin.
Yeah,
Fine.
that's
Fine.
exactly right.
Fine. So the reason why I chose cracked teeth is that although I love clinical dentistry, I hate cracked teeth with a passion.
Yeah.
I hate dealing with it because it's just there's so many challenges and variables. So the way I say it is, if there's a cavity in a tooth that's just caries with no associated crack, there is a degree of predictability in the sense that when you're communicating with the patient, you can be a bit more definitive, like, okay, there's a low chance or medium chance, depending on symptoms, stuff, whether you may end up needing root canal treatment. But when it comes to a cracked tooth, there's so much explanation, and it's like a flow chart. You have to explain, well, if you then end up having pain, then we can hopefully do root canal. But if the crack is too big, then we can't save it. We'll only really know at this point. So I find it's just a nightmare in that sense. So that's why I wanted to speak about it.
And we're seeing it so much more. I don't know about, I mean, I feel like I'm treating 1 or 2 cases a week, which never used to be the case a couple of years ago. You know, it's definitely getting more and more, probably because people are more stressed, you know. I mean, I've got a crack in my tooth, and don't know, it's probably from all those exams that I've sat. But
are you parafunctional? Do you have a history of parafunction?
Too much. I clench, I don't tend to night grind. I think I used to, but I definitely clench a lot, and my lower 7's got a crack in it.
I'm going to ask you my list of questions. So when I have my phone out, please don't think I'm texting someone. I'm actually looking at my questions. Okay. So if a patient comes in, how do you manage your situations where pain is difficult to localize and you're in a diagnostic dilemma and you suspect a crack? What is the sort of your standard protocol of, okay, I suspect cracked tooth. I don't exactly know which tooth, because sometimes you just can't see which tooth it could be. So talk us through how you'd manage that.
Well, I think just starting from the basics, because I find that really helps, a good history before we actually start the exam. So I run through Socrates, so site, you know, where they think it's coming from. And there's been studies that have shown that, you know, patients that think it's coming from a certain tooth, quite likely it's coming from that. So, I mean, I think, you know, having a good conversation, quite often with these cases, the patient isn't sure. They're like, it could be this one, it could be this one. I think it's more likely this one. So I think that is very important, actually, just get, you know, right from the onset. The second is the onset, so when it started, because sometimes patients, they present to you with irreversible pulpitis and, you know, it's very severe pain. But if you ask them the history, then, you know, they might have said, you know, I had pain on biting from around this tooth for about a year, or after that restoration was done, it's never felt right, and now I've got severe pain. So I think that really helps. And quite often you find with patients, they're not willing to divulge that information. They just say, I've got severe pain, and then you get on with it. But I think the history is actually very important. Even the radiation. So, you know, if they've got, for example, ear pain associated with it, we're now thinking lower molars potentially. If they've got pain in their eye, you know, canines, things like that. Even things that are stimulating the pain, so hot and cold, because those things will help me during my clinical examination. So when it comes to a patient and their exam, I start from all the basics. So what's tender to percussion, starting from the adjacent teeth which aren't tender. If there's 2 teeth which are both tender to percussion, then again I'll try and look for cracks. Magnification is really important. So I think with cracks you do have to be using loupes and a light if you can. Ideally a microscope is lovely to have, but I think loupes and a light you see, you know, a lot more than just with, you know, normal vision. What's
the minimum level of magnification you think someone should be using for exploring a crack? Do you have an opinion on that?
Yeah, I mean, I think if you've got loupes, it would be 5 times magnification, because it's very difficult to see where the crack extends without that sort of magnification, because you might think it's a lot more coronal than it actually is, because they go very hairline as they travel down the tooth. So I think 5 times is the absolute minimum when you're treating.
The advice I give to the advice I give to lots of young dentist students and stuff coming out and they're buying their first pair of loupes is just skip the 2.5 and 3, go straight to the 5, because you know, I went 5 and I now want 8 or something, you know. Or so, on Fridays where I get to use a scope, I'm like, oh, this is so much better. So you know, that's one side thing I just want to say. The more magnification the better, with good lighting as well, as you said. Yeah, harder to get used to in the first instance, but within 2 weeks I think you're there, you know. So I totally agree with what you're saying there.
Also the bite test, so using a tooth slooth, so testing individual cusps. When they bite down on the tooth slooth on an individual cusp, I tend to jiggle the end of the tooth slooth because that sort of gives lateral pressure on the cusps, and I find that very usle.
Can we just talk about the tooth slooth actually, because people actually use it without knowing the proper way to use it. So the curved, the spoony side and whatnot. And I also want to answer this for me, which is there any evidence to suggest that using an actual rigid tooth slooth is superior to what a lot of GDPs use is cotton wool?
Yeah, I think the problem with cotton wool is you don't get the same sensation as when you use a tooth slooth. So a tooth slooth tends to separate the tooth a little bit better because so as you mentioned with the tooth slooth, you have one end which has got a little cup on it. That's meant to sit directly on each of the cusps individually. So you test one at a time. So you put the cup end on the cusp tip, get them to bite down on the flat end, and then you jiggle the end of it. And what that does is it puts lateral pressure on each of the cusps individually, which I think cotton wool just really can't do. So I think that, tooth slooths aren't very expensive, but they total game changers when it comes to diagnosis. So I definitely recommend.
It's a good tip you give there of jiggling it. I think that's something that is something I don't always do. So I think that's a good point.
Yeah. I mean, some people will feel it instantly, but some people it's the jiggle that does it. So it's a good idea. I also find sensibility testing really good. So the other thing that, all these things are mistakes that I've made during undergraduate. I never got taught how to use a tooth slooth. With sensibility testing, it was always ethyl chloride. And the problem
not good enough.
No, exactly. Yeah. So ethyl chloride is about -5 degrees. Whereas if you're using something like Endo Frost, it's -50. So you were much more likely to get a good response with something a lot colder. So Endo Frost is the first thing I pick up. There are some cases, how you mentioned, it's very difficult to diagnose where the pain's coming from. And a good tip that I've learned recently is I tend to use hot test. So, you're taught at uni to get some warm GP and put it on the tooth, but that doesn't work very well at all. So what I tend to do is I'll get my nurse to boil the kettle, and then I will put the warm water in an endo syringe. Not boiling hot, obviously, but just warm, fairly warm. And then I will individually isolate each of the teeth on that quadrant with rubber dam and put the hot water on it. And you know what? The patients that tell you they've got hot pain, instantly you'll know which tooth it's coming from. Because they're the ones, with irreversible pulpitis, they find it very difficult to differentiate which tooth it's coming from. It's quite a little bit painful for them. Obviously, you need to tell them it's not very nice in terms of doing it, but I get the nurse ready with the suction so she can suck up the water as soon as it's done. But I find that test really useful. I've had a couple of patients referred to me recently that the dentist hasn't been able to diagnose which tooth it's coming from, and the only way that I managed to is do it with that test. So
that's a really good tip. So anyone listening, use the hot water in a syringe, isolate each tooth with rubber dam, and that might figure out which tooth it is. I have a story whereby I was dealing with a patient who ultimately ended up having cracked tooth, but the symptoms were severe pain, irreversible pulpitis type, apical periodontitis, and we're trying to figure out, is it from the top, is it from the lower, and an upper right first molar was very TTP, and we both agreed that, okay, it could be this one, but I wasn't 100% convinced, but he literally begged me to remove the upper right molar, and literally in my notes, patient begged me to remove upper molar. I was like, look, I'm not 100% sure, it could be a lower tooth as well. Anyway, took the tooth out, patient said thank you. Anyway, comes in next day, obviously he's not out of pain yet, it was a bottom tooth, and when I look at, get my loops on again, and look, actually you can see this micro chip on the marginal ridge of a lower molar, and then actually that's where it was a cracked tooth. Anyway, ended up removing that tooth, and I could visualize the crack beautifully. Anyway, the patient was very understanding because he literally begged me to remove that tooth. But we've all made, a lot of us have made mistakes like that. So this is why it's so important to make sure you get it right.
Yeah, I think you highlight a very important point though there. Your consent process was exactly right. With these sorts of teeth, even if I am pretty sure it's that tooth, with cracked teeth, when they're in that sort of state, irreversible pulpitis, patient struggling to identify what tooth it's coming from, I think it's always important to, say to them, look, I'll normally say I'm 80% sure or I'm 90% sure it's coming from this one. However, your symptoms aren't, 100%. we've got a couple of options. You either wait and let it localize more, which, sometimes some patients will say, okay, do that. And you warn them the negatives of doing that is that you can end up with an unrestorable tooth because it can end up completely fracturing. Or we treat this with you understanding that, it could be another tooth, which is exactly, how you handled it. And I think, having that discussion with the patient is just really important because, we can't be 100% sure all the time, especially with these sorts of teeth.
I think it's important for the patient to sense that actually, one, it's totally okay not to be sure and to be straight with the patient rather than, I think we'll remove this one. And then when you're wrong, everything happens. But I like the way, I think is this percentage sure, what do you want to do? Then the patient could take some ownership as well of that. So that was just my little story. So now you mentioned about the actual diagnosis being pulpitis, necrotic, that sort of stuff. So can you tell us about the cracked teeth with associated what's happening with the pulp, because that's essentially what it's all about. You can have a cracked tooth. You can have a cracked tooth, and correct me if I'm wrong, you can have a cracked tooth with no pulpitis at all, and that tooth just needs cuspal coverage, for example, whereas a cracked tooth with the whole sequelae. So tell us a little bit about the sort of different types of diagnoses you can have with a cracked tooth.
So cracked tooth syndrome means that the tooth is vital. So that's not a diagnosis for a necrotic pulp. So you have cracked tooth syndrome with a reversible pulpitis. And for that, obviously, patients got maybe pain on biting, constant ache, pain that doesn't last more than a couple of seconds, all the normal things. And then you've got cracked tooth syndrome with irreversible pulpitis. And for reversible pulpitis, I tend to tell the patient, there's a couple of ways of managing this. One is, we could do a root canal treatment. If, that would be, we take the pulp out and it solves your problem as in terms of your symptoms, or we could handle it more conservatively and just put a cuspal coverage restoration on it. And, most patients will say that's what they want because every patient wants the most conservative treatment possible. And there's quite good evidence for this. So there's two studies, one by Signor et al. In 2007, and I think he treated about 43 teeth with reversible pulpitis with a crack that was diagnosed, and he put a direct composite onlay on them, and I think about 96% or 95% were asymptomatic at 6 years, which is a fantastic result. That's for a patient. Good. They've got reversible pulpitis, they have an onlay on it, and everything gets fixed for them. But there was another study done in a similar year by Krell and Riviera, and they said about 20% of teeth that had cracks and reversible pulpitis became symptomatic after a crown was done. So I think that's quite interesting actually, because the first study did an onlay, composite onlay, quite technique sensitive. And the second study did crowns. So I think the main difference in the results there was mainly because an onlay was done. So I think for teeth with reversible pulpitis and cracked teeth, we should be placing onlays. We should be hopefully, doing things like immediate dentine sealing, making sure the temporary onlay we put on there is very good, so we're not getting leakage, because this all helps preserve the vitality of the pulp. However, if you are doing that, I'll always say to patients, there is always a risk that the tooth can become necrotic or symptomatic. And in that case, we are going to have to strip this restoration off it, investigate the crack, see if it's restorable. If it is, we're going to put something else on there. So that conversation is very important, because every procedure or any crack or caries, it's all an insult to the pulp. So we've got this tooth which has had a little bit of an insult because it's got a crack in it, probably a restoration in it, and then we're doing another insult by putting this onlay on it. So that's enough to sometimes just tip a tooth with reversible pulpitis over the edge. So I think that consent process is very important.
Well, Kreena, if money was no object, I would always in that situation where my diagnosis is cracked tooth syndrome and we have a reversible pulpitis, if money was no object, I would go for an indirect onlay. So be it gold or lithium disilicate, whatever, for example. However, it's not nice when you've had to deal with a cracked tooth with reversible pulpitis, and then after your intervention, it becomes irreversible pulpitis or becomes necrotic without the patient realizing, and then eventually it's an abscess, and then you're drilling through your investment or the patient's investment or the cuspal coverage, what you've done. So sometimes a good interim is, like you said, a composite direct. I do a lot of these cuspal coverage just to see how it's going to go, and I can send the patient that, look, after a couple of years, if all is good, I think we really should, for longevity reasons, then progress to an indirect restoration.
Yeah, I mean, I 100% agree. I think some sort of temporary measure is always good. The only thing I don't like about the direct composite onlays is I feel like the indirect ones are a little bit more stronger, in the sense that when you're biting on the tooth, you've got a bit more stability to hold the crack together. So maybe, I mean, a slightly shorter term, see how it goes, and then put an indirect on there a bit sooner.
Completely agree, and something that Jason Smithson taught me. He's not that big of a fan of composite onlays, to be honest with you, because he shows all these studies where the rigidity of ceramic is needed to really get that cuspal coverage and actually prevent the flexure of a tooth. So the point well taken. So I think what we're left off as where I sort of interjected with a story was you were talking about now reversal pitus, part of the cracked tooth syndrome.
Yeah, so if the symptoms have gone a bit further and we're on irreversible pulpitis now, I think that's what you mentioned, didn't you? Yeah, so if we're on irreversible pulpitis now, we manage that very similar to if a tooth is necrotic. So those two are managed the same. So what I would do is I would then explain to the patient on the outset that the treatment of these teeth is a lot more unpredictable. Both in the short term and in the long term. So short term, we're going to our treatment plan would be to investigate the crack. So what I would tend to do is, if it's irreversible pulpitis, extirpate and see how far that crack is going. Same if it's necrotic, I would go into it and have a little look. At that point, we've got a lot more information on the extent of the crack. But in the short term, it's unpredictable because, say we do treat these teeth, the crack may have extended further than what we can physically see. So we stand the best chance of seeing how far it's extended with a microscope or with high magnification loupes. But even with those sort of devices, potentially there could be micro cracks that have gone beyond the level that we can see. So short-term treatment can be unpredictable, although we try and minimize the unpredictability.
This is what I mean with patients, cracked teeth is so complicated because of that, and you're constantly sort of having to defend yourself. You're constantly digging in front of the patient. This is why I hate cracked teeth so much.
Do you know, the way I find it very useful to show them a picture. So I've got one folder on my desktop with cracked tooth in it, and I've got this sort of sequential look at a tooth all throughout me investigating the crack. And I find that patients don't understand what I'm saying until I show them those pictures. And when I see them, it's like a light goes on in their eye, and they're like, "Oh, I understand why now you don't know, why you can't tell me, because I can't see where it goes." So you can, you can show them the pictures, and I find that very useful.
Well, this might be a good point for me to show the people watching right now and you a cracked tooth which I opened up due to irreversible pulpitis, and see what it looks like, and then get what do you see from your lens of the world? Can we do that?
Yeah,
okay,
of course.
Let's do that. Fine. So share screen. Right, so let's make that bigger. So this is a lower right molar. Diagnosis was irreversible pulpitis, raging, lots of toothache. Anyway, opened it up. Hyperemic pulp, and what we're looking at here is the distal marginal ridge, the crack extending into pretty much the pulp chamber. Now, if I was to zoom in, I mean, this is very clear where my mouse is now, the sort of higher part. That's very clearly cracked. The bottom, you can still see the crack line.
Yeah.
So tell me, is this one for the bin or not? Or do you need more information?
For me, this is probably one for the bin. Not because of the extent of where the crack goes to, because I think that it's going slightly into the black area, but it looks, that doesn't bother me as much. What does bother me is the width of the crack at the coronal aspect. So we can see the tooth is pretty much in two parts. You can almost see debris coming in, pretty much at the level of the CEJ. I can see that crack is about, 0.1 or 2 millimeters wide. You've got debris in there. So I think that is the reason that crack width is the problem for me, not the extent that it's going to, because when I look at cracks, as long as it's not crossing the pulp floor or it's extending, very far into the canal orifice, usually even a millimeter into the canal orifice, I will treat that sort of tooth if the patient is keen for me to. But the width of this crack is what I think is unrestorable.
Well, that was a massive dilemma for me at the time. It was really umming and ahhing, and the patient. So I ended up doing a root filling for this tooth. But I take your point. I think now, if I was to look back at it, assessing the width, it's very reasonable to say you shouldn't treat that. I think it's been 3 years now, touch wood, all is good, but I don't think this will be there in another 5 years personally. But it's interesting how you say that. Yeah, no, I enjoy your sort of look on it, and I learned something there to actually not just assess the depth, but also look at the width, and you see that you can see debris coming in, and that's a red flag, I think.
Yeah, I mean, to be honest, there isn't much evidence when it comes to, which teeth we should treat and what teeth we shouldn't treat. There was actually, I was going to do my own study on it, because I was treating a lot of these teeth, which, if you look at the previous papers, they were saying that they were unrestorable. Before, if you look at the evidence, it said that if a crack is going, to the level of the canal orifice, that's for the bin, and that, there's very, very, high risk of failure when it comes to treating cracks. But if I did that, then so many of my patients would lose their tooth, and in my mouth, I would be treating these. So I started treating these sort of more severe cracks about 5 years ago. I've had great success with it. And there was a paper that came out last year, actually, which has shown very similar results. They treated quite extensive cracks, so cracks that extended just into the canal orifice, or if there was about 5 millimeters pocketing, isolated pocketing associated with the cracks. And they had a great success rate. They had about 100% survival at 2 years and 96% survival at 4 years. So I think actually, look, as long as they were treated properly, which I'm sure we're going to go on to the management of these teeth, but as long as they were treated properly, the success rate was very, very good. I think the main thing, as you treated with that one, it would be just telling the patient, actually, normally for me, when I'm treating these cases, before I even start, I say, I won't know if I can treat this or not until I open it up and investigate it. Once I have opened it up, I can give you a rough percentage of what I think. So, for example, with that tooth, I would have said, 50-50 or 40% or whatever. And I would have given them a percentage at that stage once I'd opened it up. And I think most patients are happy with that. And it's that percentage that they then decide. I mean, I've treated a dentist a couple of years ago, and, obviously he's well informed, he very understands everything. And I said to him, look, I think 50-50 for this. It was could see the crack. There was an isolated 5 millimeter pocket with the crack line. And I've treated it, and it's still in his mouth. So I think as long as we've properly consented patients and spoken to them about the risks, long term, short term, we should be treating them.
I think just an interesting observation. I think with all realms of dentistry, the decisions that we make as clinicians. Now, if you're someone who's quite good at placing implants and you come across a 50-50 crack, you're probably going to go towards the implant, because, everything, when you have a hammer, everything looks like a nail. Or if you have a really good endodontist beside you, or if you're really good at endodontics, you probably have a crack at it, excuse the pun. So it's just one of those things, isn't it, in life. So you've answered one of my next questions, which was how far into the orifice. You said about 1 millimeter. Even then, obviously, taking into account all the other factors as well. So
if the crack extends across the pulp floor, for me, that's a definite no-no.
Sure.
If there is an isolated pocket more than about 5 to 6 millimeters, for me, that's a no-no. Although there have been studies that have shown good success rate with up to 7 millimeter pocketing.
Wow.
But that pocket indicates that the crack has gone into the root. It's traveled into the root there. So 5 millimeters for me is a cut-off. And if I do have any isolated pocket, that's an immediate me telling the patient, look, short term, this is a lot more unpredictable. And crack width is very important. So those are the factors that I look at.
Brilliant. So the next question is, I think you've answered this already, basically, about the evidence base for how long root canal treatment can last with patients with cracks. Do you want to mention anything else?
Well, there was also a systematic review that was carried out last year. I've got the name here somewhere. Here, Oliveira et al. It was a systematic review on all the evidence for cracks. And they said that there was an 88% survival at 1 year and an 82% success rate at 1 year. The main significant factors that they found was it wasn't how many cracks the tooth had, or the tooth type, or the status of the pulp, so if it was necrotic or irreversible pulpitis, but it was more that if there was a perio pocket associated with it.
Wow.
So that was the main factor. But it was was the Davis and Sharif study that I mentioned earlier. That was the one that I think is very, very good. The main sort of outcomes of that study were that we place an intracanal barrier. So, for example, with teeth with cracks, so the one that you showed, for example, what I would do is once I've obturated that tooth, I'd normally put composite below the level that I can see the crack extending, because we know that GP leaks. It's not a very good material. It's only good for root canal fillings. It's not good at preventing leakage. So one of the main outcomes for this study was putting a microscope assisted intracanal barrier. So something, far down the canal. And I think that makes a significant difference. The other outcome was what they said is they took the tooth out of occlusion. Then they recommended a cuspal coverage restoration as soon as possible. So when I treat these teeth, I tend to put a ortho band around the tooth, because as dentists, you don't know, when we're treating difficult cracks, especially the bigger ones, you worry that, I normally put a composite core in the tooth and leave it like that. But the ones that are bigger, I find an orthoband really useful. So I just take a very thin slice mesially and distally, which is what the dentist would take when they put a cuspal coverage anyway. And I cement an orthoband with GIC. So I pick a band that's going to be very tight fitting, and I've got a bite stick for the ortho band, so that they just bite on it. It clips on, very easy to place. It doesn't take very long, and that just holds that tooth stable until the cuspal coverage restoration is done. Because dentists get busy, if they can't, if you can't get that patient back in your diary for another month or something like that, I think the band is really useful to help hold things together. But I think that's another conversation for the patient. Before you start, it's saying that you're putting a big investment in this tooth. You're going to have a root canal treatment, and then for me, you're going to have a cuspal coverage straight away. Yep. And then we see how it goes. If this doesn't work, then it will have to still come out. And if it does work, it might last you many years, but there is a risk long term the crack can extend and the tooth may need to come out as well. And it's a hard conversation to have with the patient, because it's not easy, and it does take time, it's to have that conversation. But I think it's so important, because then they suddenly, they understand you and them are in the same boat, and you're traveling, this line together. And I find that the reviews, they come back and they say, Kreena, it's still there, it's fine, it's and we both celebrate together, So I think.
I like that. It's undersell, over deliver, isn't it? Really, it's the crux of all treatment conversations, and consent that's a very important part of it, especially with cracks. That's why I hate it so much. I don't like giving patients bad news all the time. Like, well, it's really dubious, and it's just when a cracked tooth is involved, I'm always like super pessimistic. Yeah, me too. I give them the percentages, the rough percentages, and then I sort of stand there, and it's hard to be silent in that time while they decide. Yeah. But I think the main thing is just be silent, let them make the decision. A good tip for young dentist communication wise is that never own the patient's problem. Remember, the crack is in the patient's tooth, not in your tooth. So make sure you dissociate yourself from that problem. The problem is out of your body. It's in someone else's mouth and their tooth specifically. So really give them, as a professional, all the information you need to give, and let them come up with the decision. Don't own it. Don't get emotionally involved in that patient's decision. I used to do that quite a bit, I think. So. I'm very guilty of it. Yeah, okay. I'm very guilty of it. I think, I'll be thinking sometimes of a tooth that I, should have treated or not treated, and I'll be thinking about it at night time, and it's not a good thing to do. I think the more you practice that conversation and say, you have it a few times, and then you get used to saying, okay, look, this is your tooth. I've had the same problem in I normally tell them about my story, actually, because I was getting pain when eating raspberry seeds, and I would get a short, sharp pain when eating, and I was convinced it was my 6, and it was my 7. The most common teeth to crack in the mouth are lower 7s first, then upper 6s, then upper 4s and 5s. So studies have shown that, and it was my lower 7. I was very close to getting a cuspal coverage put on my number 6 tooth, and it was only a little bit later, I had a raspberry seed, and I asked someone, well, where is it? And it was on my lower 7. So I always tell them that story. And I find that patients quite like that. If you tell them a story, something that happened to you, they're like, okay, she understands, that
this is a problem.
No, that's a great way to communicate with your patients. So the last question I have, I think, is there any other points you want to raise about the consent conversation? Or because one thing I want to say actually was, when I'm consenting patients for any treatment, not just root canal and cracks, I always love to give them percentages according to the evidence. I think that's a very good thing to do medico-legally. So, for example, if I'm doing a resin minor bridge, I say, well, the studies show that if they last 4 years, they'll then go on to last 10 years, and 80% success rate at that point. And I'd like to give them that sort of information. So, what do you do in terms of consent? And do you give them like that sort of information that I've just described?
Yeah, I mean, it's difficult because there isn't much evidence out there apart from this paper that I mentioned to you. So the two papers, the Davis and Sharif one and the Oliveira one. Yeah, I mean, those are the two main papers, and they've got very good success rates. And so I don't like to quote that because obviously it is difficult. So normally what I will say is if it's a very minor crack, I will probably give them about 85%. That's when I start. And if the crack is very extensive, so probably the one that you showed, that for me is 50-50, something like that. So it varies on how wide it is. If there's an isolated pocket, it instantly goes down for me to about 75%. But just because these things are unpredictable, and I think it's a large investment for a patient, so it's very important that you, like exactly how you said, that you sort of undersell and over deliver. So yeah, those are the sort of percentages that I tend to give.
I take your point. I think maybe you're right. Maybe with endodontics and cracked teeth, you don't want to be quoting them as good as figures as in the studies, because it sort of goes against the philosophy of undersell, over deliver, and it's just so variable and unpredictable, and that sort of stuff. Yeah. So the last question.
From personal experience, actually, the success rate is over about 90%. I think.
Well done.
So it's
that's because it's you.
No, but I do think. I mean, even your patient, the one that you treated, that's a fantastic result that you've got that patient 3 years out. Is it 3 years?
3 years so far.
Yeah, I mean, it's a fantastic result. That patient's kept that tooth for 3 years. And for me, in my mouth, that's, I'd definitely be going for that sort of option. But I think sometimes for other patients, we're so scared in this litigious world, to treat something and then be told off for trying your best. So I think you have to be careful, but at the same time, we want to do the best for our patients.
Well, you're completely right there. We're less inclined to give it a go anymore because of the climate we're in. So the last question I have for you is there any evidence perhaps about, well, some people say that when you have a crack that you should chase the crack until you don't see any crack anymore. Whereas others are like, no, don't chase the crack, because the theory is that the vibration of your burr is actually causing more micro cracks. And that's the camp I'm in, actually. So I follow the principles of someone called Pasquale Venuti, who's a fantastic general dentist in Italy who lectures all over the world. I saw him in Sydney a few years ago, and he was talking all about cracks and whatnot and how he doesn't chase cracks. So I changed my practice based on that. But I don't know, am I doing the right thing by not overzealously chasing cracks?
It's difficult to say because, again, there's very little evidence on all of it. If there is a vital tooth with reversible pulpitis, then I definitely wouldn't be chasing any crack. I would be going straight for my cuspal coverage. What I find is when I don't chase them so that they disappear, but what I like to do is I quite like to open the tooth so that I can probe directly at the level of where the crack is. So, for example, if there is a proximal contact, we can't probe properly interdentally. So what I will tend to do is I'll open the crack just enough so I've removed the contact so that I can probe directly where the edge of that crack is. And the reason I do that is I think it does change my percentage of success that I offer the patient, because some cracks look, not too bad. You open that bit, suddenly you've got an 8 to 9 millimeter pocket at that level, which would significantly change my management. Whereas for others, you probe, they're a little bit wider initially, and you probe and there's no pocket there. And it may be that I would then go and save that tooth. So I don't agree with chasing it to get rid of the crack by any means, but I do like to know. For me, it impacts on my treatment, so I quite like to open it up just so I can probe that contact there.
That makes perfect sense, because you're opening. What you're essentially doing is you're opening the contact, which is something that would have happened anyway, because that tooth would have needed a cuspal coverage restoration, because that's exactly where the crack is anyway.
Yeah, potentially. I mean, it's not ideal because if we remove the marginal ridge on a tooth, we do significantly lower the strength of that tooth. So if we could preserve it, it is nicer. I think I don't get the information I need from doing that. So at the moment, I am enlarging those ones so that I can probe and check. If the crack is very small, then I don't. So if I've opened an access and the crack is very hairline, it's not got any staining coming through it. You know, sometimes you see cracks and you can just see that there is a crack there, but it's not got any black staining or anything like that. For those, I won't bother because I'm thinking, it's fairly minor anyway. The only time I do sort of open them is when I worry that tooth has become necrotic due to the crack. So if we look at most teeth that we treat, if we take out an amalgam, quite often we see minor crack lines. Those I will never chase. But if it's a tooth that's become necrotic or pulpitic because of the crack, that's when I want to investigate them a bit further.
Okay, brilliant. Well, the only thing that left a question with me now, based on what you said, was I'm trying to think of my references now. I think it's either Reintrope 1985 or Aquilano 2002, I think, or 1998. I'm trying to think which year it was. But the whole thing about cuspal coverage after endodontics and how the loss of marginal ridge significantly weakens the tooth. Now, in those situations, typically in the absence of cracked tooth, if you've got, for example, occlusal caries in a molar, and that has led to, let's say, irreversible pulpitis or a necrotic tooth, because the marginal ridges around the entire 360 degrees of tooth is preserved, for me, in my book, that it can often get away without a cuspal coverage restoration. Just a well-bonded composite can do the trick. Whereas if you have endodontics and a marginal ridge involved, then for me my default is an onlay or a crown if necessary. But if you have a scenario where you sort of describe whereby you might have a cracked tooth with irreversible pulpitis, but there is no previous restoration, there's no involvement of a marginal ridge. See, because it's a cracked tooth, I would still be inclined to put a cuspal coverage restoration on it.
Yeah, 100%. I think if there is a crack in a tooth, that tooth definitely needs cuspal coverage restoration because, teeth, when you've had endodontic treatment, they become weaker for a variety of reasons. One, like you mentioned, is the loss of tooth structure. And there's a great study by Rare et al., which shows that if the marginal ridge is removed, it reduces the strength of that tooth by about 63%, whereas for a small occlusal access, it's about 5%. Occlusal access doesn't contribute loads as long as we've kept it fairly minimal. But there's other reasons why the tooth becomes problematic. One is proprioception. So, there's pluses or minuses. Is there proprioception in the pulp? Isn't there proprioception in the pulp? But there have been studies that have been done. It's Rando and Glance, actually. Yeah. So there's a really good study called by Rando and Glance. What they did was they put force on non-vital teeth and vital teeth, and they found that non-vital teeth took at least 2 times more occlusal load than vital teeth. So that it shows that there probably is proprioceptive fibers in the pulp. Because non-vital teeth, you can put a lot more pressure on them without you knowing,
Are you sure you mean non-vital or you mean vital? You can put more force in a... Yes, you can. Teeth. Yeah, you can put... I see. So in the mouth, when there's a non-vital tooth, it can take more force because there's no proprioception to warn it that there's this force. Okay, fine.
Exactly, yeah. And actually they had to abandon that study because they kept breaking the non-vital teeth. So there's obviously the medicaments and irrigations we use, so sodium hypochlorite, all of that causes problems with the dentine and can result in fractures. There's lots of reasons why endo itself weakens the tooth. So that in itself means that a cuspal coverage restoration is a good idea. In terms of if there is just a small occlusal access, sometimes I will still recommend a cuspal coverage restoration on those patients, depending on if they're a parafunction patient or not. So if that patient has parafunction, all these factors with endo associated can cause problems in terms of how brittle the tooth is and all those sorts of things. So I will still sometimes in some cases recommend a cuspal coverage restoration, even with a small occlusal access. If there's a crack, definitely, because we want to bring that tooth under compression rather than flexion. So the cuspal coverage restoration will mean that when we're biting on the tooth, it's under compression rather than the two cusps flexing apart and being under flexion.
Awesome. I think that's quite a comprehensive, 40 minutes, whatever we've been done on cracked teeth. Anything else that you want to tell the listeners about cracked teeth in terms of something that might think is relevant to them?
I think it's only when it came to the diagnosis part. The other few tips are transillumination is very good. Staining can be very good. So using something like methylene blue, you can get dye that sometimes helps you identify cracks. And sometimes if there's a large restoration in the tooth, we can't see cracks at all visually. So if you are very stuck on which tooth is causing the problem, you can just say to the patient, look, I'm not sure. We can remove the restoration in the one that's more likely, see if I can see a crack. If not, maybe, move on to another one. So those are just little tips on diagnosis as well.
I mean, as a GDP, there's so many restorations I removed to reveal these nasty cracks. And at that point, you pull out your camera, you take your photo out, you show the patient. It's all part of the consent process.
Yeah, definitely.
Brilliant. Well, Kreena, it's been amazing time has flown by speaking to you about cracks, and I think you've really given me some good definitive answers of the questions I wanted, and I've learned a few things about assessing the width, the jiggling of the tooth slooth, and also I do agree with you, parafunctional patients, even if they've only got a sort of a small access cavity, I am a bit more inclined towards cuspal coverage. So there's been loads of gems there. Thank you so much, Kreena.
Oh, thank you so much for having me. I really appreciate it.
If you want to learn more, how can we follow you and find out which other education that you're involved with?
I guess I post a lot of my cases. For anyone that's interested in endo, I post a lot of my cases on my Instagram, which is at Kreena Specialist Endodontics. And I'm starting up an online endo course because I don't think there is very much out there. And I constantly get asked about, from people in different countries, even this country, because online learning is so important now, as with your podcast. If you can learn from the comfort of your own home, it's very nice. So I'm launching my own online endo course pretty soon. So yeah, watch that space.
So thanks again for listening all the way to the end. And within a couple of weeks, I imagine you can go on to Dental Tubules and answer the questions and get your enhanced CPD for that. Gosh, I hope by the time this episode's out that lockdown is finished. We're sort of recording in the midst of lockdown. So I hope everyone is safe and well and their families are all good. And we're going to hit back into practice with all guns blazing. And as always, thank you so much for listening. If you like the content, please subscribe, like, and share with your dental colleagues. And please, of course, leave me a 5-star rating on your podcast platform. That's how my podcast actually grows. So please, that's very important. I really appreciate it.